Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today's topic is double crush syndrome. And if you were to look at what research says, you would think it was an extremely rare occurrence, very low percentage of people that would be diagnosed by most Western researchers as having double crush syndrome. They mostly think it happens from things like earthquakes and people getting trapped in a building with something on them. And then when they take the cement block off the person, they have a double crush syndrome. Now, the definition of a double crush is two or more compressions of the peripheral nerve, different locations of compression on the peripheral nerve. So one of the most common double crush scenarios you're going to see when you start treating a lot more neuropathic pain, numbness, tingling, is the thoracic outlet, the neurogenic thoracic outlet, as the first crush, and then the second crush, usually around the elbow area, distal to the elbow, and sometimes even proximal to the elbow in the triceps. The arm, the nerves of the arm for things like pronator teres syndrome, carpal tunnel syndrome, radial tunnel syndrome, and cubital tunnel syndrome are going to be made worse if there's a double crush, usually from the pec minor and middle scalene, and I would say upper cross syndrome, compressing the brachial plexus at the thoracic outlet. Now, here's where I differ from what researchers say. As somebody who successfully treats this sort of neuropathy on a regular basis with, and I'm not a surgeon, I'm just an acupuncturist, I can tell you that there are subclinical compressions that are irritating the nerve more proximally so that the distal issue is worse. So you still need to check for it, and it will always help you to improve the person's upper cross syndrome, to make sure that pathway is as good as possible, so that when you're working farther down, more distally, on the most painful part of the nerve compression, that you get better results. So you'll see the same thing with foot neuropathies, numbness or pain on the top of the foot and the shin, and numbness, pain on the bottom of the foot. Those compression neuropathies are super common. You see them, usually the person has some sort of history of sciatica, not necessarily, but almost certainly a compression in the low lumbar area 4, 5, and S1, L4, L5, S1, that will cause the lower leg muscles to tighten and start to compress the nerves. So I successfully treat foot neuropathies on a regular basis. And since the medical world pretty much treats the same neuropathies with pharmaceuticals, which doesn't help anything. I mean, it might make the pain less, but it doesn't correct the problem. I think I can tell you that I know that it's usually a double crush. So the most obvious ones are the ones I've talked about in previous episodes, like the superficial peroneal nerve causing pain or numbness on the top of the foot, dorsal foot neuropathies, and that's usually in the shin as well. Also, numbness, pain, tingling, bottom of the feet. You're going to look at the tibial nerve and the tarsal tunnel. But also, a double crush for that one can be in the soleus at something that's called the tendinous arch of the soleus, the top of the soleus. There's a big, thick tendinous arch that runs right over the tibial nerve, and that can be a double crush. And you're going to find it by pressing on the upper soleus area, about 4 fingers below the popliteal fossa. And I would tell you, even if you don't find soreness there, the person already has numbness in their leg, okay? It's nice to find soreness and really feel confident before starting needles that your diagnosis is correct. But I have found sometimes you just have to say, okay, what if this is so old that there's no longer sensitization of the muscles from the compressed sensory part of the nerve? So you're going to go for your instinct and still treat the soleus. And I tell you, you will increase your success rate by treating, even if you don't find painful signs of nerve compression there. So I'm going to say it's like a subclinical peripheral nerve entrapment, because you don't have a diagnostic way to prove that compression, but your success will be proof enough. You need to also consider the deep rotators of the hip that can cause sciatica. The person may not have any sciatica. They may have had sciatica before, but no longer do. The muscles are still tight. If you haven't treated them for that sciatica that they had many years ago, I guarantee the deep rotators are still super tight. And so they might not have pain from the sciatica, but that double crush could be increasing the symptoms more distally. So these entrapment zones that can cause a double crush need to be considered regardless. Even if you can't necessarily prove that there's pain in the gluteal area, what you can do is check their hip internal rotation on both sides, and the affected side is going to be worse. If they have bilateral numbness, then test their internal rotation. If they have like 5 degrees of internal rotation instead of like 45, then you're on the right track. And the worst thing that could happen is that they just feel more mobile and better. But most likely there is a double crush there that could increase symptoms for both the tibial and the peroneal nerves. So consider the deep rotators for sure for your foot neuropathy patients. So forearm, you're going to look at the thoracic outlet. You can find neck muscles that also can compress in that C5, 6, 7, 8 range. Typically, if you are testing, you'll find more likely that it's more of a neurogenic thoracic outlet that's causing arm neuropathies. The neck can be treated, and sometimes I do want to treat it, especially if it's tight. Most people with a thoracic outlet compression have terrible neck as well. It's the whole upper cross syndrome. So you do want to treat that. I just don't want to confuse. I don't want to get this confused with me saying you need to treat the segments for this to get better, because in most cases that will not be the case. However, it's not considered a double crush when it's coming from the spinal segments, but that can also contribute. usually that's the origin of the pressure that caused the distal muscles to get out of balance. So it is a consideration. I just don't think you're going to have to go back to it every single treatment in order to solve the problem. Whereas you are going to have to correct the upper cross syndrome for the thoracic outlet, and you do need to take all pressure off of the nerve or nerves that are affected in the arm and hand, and that's going to be mostly muscles around the elbow, just distal to the elbow, sometimes a little bit proximal to the elbow. So, and I've done episodes about those, so you can refer back to those. But double crush is a legit thing. It's kind of controversial because, like I said, a lot of Western medical research thinks that it's just like something that randomly happens to like earthquake victims. Um, I'm going to say it's like tons of my patients, and you would be wise to look for the double crushes for any kind of neuropathy that you're trying to solve, because it will increase your results enormously, so fast. um Everyone has a tight soleus. 60, 70, 80-year-old people have not just tight but like ridiculous ischemic soleus, and it needs your help. um and that brings me back to the blood flow question for those neuropathies. Blood flow is so important, especially foot neuropathies. Our leg muscles get so ischemic over time, and nerves need a blood supply. So always consider that blood flow is another thing to be working with your patient on, helping them find something to improve their blood circulation. If it's not contraindicated for them to take something like a beetroot supplement that'll increase nitric oxide, that's an awesome thing to do. Making sure they get all their B vitamins, um, the good electrolytes. Make sure D3, everything that you can do to help the metabolic processes. Um, but blood flow is so important, and there are lots of ways to increase blood flow with heat therapies, sauna, exercise. There are vibrating plates now that can help. But part of it is going to be homework for your neuropathy patients for foot stuff. You got to get that blood flow going, because you can take pressure off the nerve, but if it doesn't have a good blood supply, it's still not going to wake up the way you want. Um, what else? Trying to think if there's another double crush that I I personally, this is probably controversial too, but um I personally think that the trapezius is a double crush for occipital nerve entrapments from the suboccipitals. I think the trapezius aponeurosis can compress the occipital nerves at the back of the head, but I personally think a lot of times the occipital nerves are more entrapped by suboccipital muscles, and the trapezius is acting as a double crush, because it does pull on the back of the head, but also because active trigger points in the upper trapezius seem to increase irritation of the occipital nerves. I think because the aponeurosis becomes irritated like a tendonitis, and that irritation is increasing the occipital nerve entrapment from the suboccipital. So I personally think the upper trapezius can be a double crush for occipital nerve entrapments by the suboccipitals, even though it alone can do some entrapment of the occipital nerve. So so I think that is definitely a situation to look out for. What other double crushes can I think of? Those might be the only ones on top of my head, but the ones that I wanted you to think about were the soleus, the arch of the soleus that can compress the tibial nerve, the deep rotators in the hip that can compress the sciatic nerve, the pec minor, and I'm going to say pec major, lats, um, all the muscles that can increase the upper cross syndrome and shrink the space for the brachial plexus in that thoracic outlet. The scalenes and yeah, for sure, scalenes and pec minor, especially anterior middle scalenes, all can increase the pressure in that thoracic outlet. And it doesn't, I like I said, it doesn't necessarily have to pass the ruse test, in my opinion, to consider treating it. I think that there could be some, like, subclinical irritation or compression of the nerves that would increase the acetylcholine and irritation further down. Um, so I feel like if you have suspicion that it's increasing the pain further down in the other compressions that you're working on, then absolutely treat the upper cross syndrome. Treat the spinal segments if you think those neck muscles are increasing pressure on the nerves. Um, I guess that's it for today, huh? Okay, so double cross syndrome. Look out for it, and it is probably worth doing some Google searches just to see what has been said about it. But um, I know Dr. Trescott talks about it, and she definitely, in her world of peripheral nerve entrapments, knows how valid it is to consider double crush on many, many patients who have not had a building collapse on them in an earthquake. Okay, so have a great day, and I will talk to you soon.